Thank you for joining me today for this episode of Conversations in HIV. I'm Dr. Rafael Landovitz from University of California, Los Angeles, here today with two of my colleagues, Dr. Meredith Clement from Louisiana State University and Dr. Hyman Scott from University of California, San Francisco. And we're going to have a discussion on successful strategies to implement PrEP and maintain patient engagement. In this section, we will discuss a challenging case of a patient who's somewhat wedded to the idea of staying on oral PrEP. So a patient that I saw recently in clinic that I would really love both of your thoughts on is Skylar. He's a cisgender man who has sex with other men, and he's got a complicated medical history with multiple comorbidities, and he's about to start a new relationship. So his past medical history is really notable for the fact that he has pretty difficult to control type 2 diabetes mellitus, moderate chronic kidney disease, stage 3, and high blood pressure that's also been somewhat difficult to control. He came into the office seeking advice on how best to avoid HIV in the context of this new relationship, and his partner is someone who's living with AIDS. And so his partner, in particular, admits to struggling with taking ART regularly. He had very low T cells early on in his course. Currently, they're much better. They're in the 300 to 400 range, but he still is struggling with ART and has only intermittently been suppressed on antiretrovirals. He's mostly adherent, but the virologic outcomes belie perhaps a level of adherence that's not quite consistent with what he's able to at least admit publicly. And as a couple, they really don't like using condoms. So as you are going to talk to him about various HIV prevention strategies and approaches, he does agree to initiate PrEP, and someone had already started him on TDF-FTC. So you see him for the first time in a while, and it's just 1 month follow-up after starting this TDF-FTC PrEP. And you send he had some labs in anticipation of the visit, and his creatinine clearance that had been sort of stably about 70 milliliters per minute now has dropped to 55 milliliters per minute. A urinalysis is normal. He doesn't have any proteinuria. He's not spilling glucose. And even before this same visit that you're seeing him at, someone had seen those abnormal values and asked him to do a recheck, and that just comes back as he's walking into the office that his creatinine clearance has decreased even further, and it's now 45 milliliters per minute. So, Dr. Clement, what would you do? Are you happy with keeping him on the FTDF, or do you think something else might be better for him?
Yeah, I'm probably not that happy about keeping him on TDF, FTC, or FTDF because of this decline that we're seeing. Once folks fall below 60, and even when I see that trajectory early on, I get a little anxious about it. And yes, certainly if they're below 60, I wouldn't prescribe it at all. And so he's someone I would talk to about different options. I think highlighting there your option 4 or 5, either a switch to TAF-FTC, because he's at 45, he's not below 30, he still could qualify for TAF-FTC if he is, like you say, wedded to this idea of a daily oral regimen. Or you could start the conversation about long-acting injectable cabotegravir. It sounds like maybe that's not something he wants as much. I wouldn't reduce the dose frequency like we do sometimes for people living with HIV who have declines in renal function on TDF-FTC. And it sounds like he's probably having regular enough activity that 211 doesn't make sense for him. And that regimen is only really approved for TDF-FTC anyway, which we wouldn't give him based on his creatinine clearance.
Dr. Scott, how would you approach it? Do you sort of agree that either a TAF-FTC regimen or possibly an injectable, if you can talk him into it, would be good, or do you have a different approach?
No, I agree, and I think I would even take a step back and sort of talk about when he initially started the FTDF. He had some risk factors for actually having this happen. He's 50 years old. We know that older individuals often have more declines in their creatinine clearance in the setting of using FTDF. He's got a pre-existing hypertension and diabetes, and his baseline creatinine clearance is actually below 90. And so we know that when individuals start at that level, that they're at higher risk of dropping below the thresholds that we feel comfortable with FTDF. So I would try to frame it for him around, these are some of the risks, these are some of the concerns that we would have of you starting this from the beginning, and that when we're seeing it, we do want to act upon it, and that action would likely be switching to a regimen that's likely to have fewer renal side effects, including FTAF or cabotegravir.
So that's really interesting. So you brought up data that's sort of was generated from your home institution of UCSF from Monica Gandhi and Al Liu, right? That people over the age of 50, people with pre-existing renal disease, particularly those with a creatinine clearance under 90 to start with, are at increased risk of dropping their creatinine further, usually below the threshold of 60 that we feel comfortable using TDF-FTC with, if they're starting from those sort of baseline parameters. So I guess, would you have even started this guy on FTDF from the beginning?
I would have offered it, but I probably would have given those caveats to him. I think one of the things we try to do is, allow people to make a choice about which regimens they want to take, but also give them anticipatory guidance around, so these are some things that might happen. These are the things that I would recommend doing if they do, so that it's not a surprise. If somebody really wants to start a regimen and then 3 months later you say, well, you can't continue that regimen, at least you've sort of planted that seed for them that, this might happen and this is how we would go about responding to it. So it's not sort of taking away something that they, desire, but sort of framing it of how we're going to make a transition to keep you healthy.
And I think knowing that we will monitor those patients more frequently can be reassuring for them too.
I think that's a really important point, right? Because the current CDC guidance for people without risk factors for renal dysfunction is now that we're going to monitoring of creatinine clearance just once a year, right? And there is that important caveat that it's important to keep in mind, right? That people who are starting from a lower baseline or have risk factors, we still may want to be checking creatinines on those people every 3 to 6 months. So I'd love to ask both of you, because this is sort of very, very much, I think, in a lot of HIV prevention providers' minds these days, right? We're seeing a lot of ads on TV for newer PrEP strategies, and I think patients respond to that by coming into the office and saying, well, shouldn't I be on X? But, there have been some discussions about safety differences, renal differences, bone differences, and then some discussion about effects on lipids and effect on weight. How do you balance those considerations when you're sort of offering PrEP choices to patients?
I have found that a lot of patients coming into my clinic come in concerned about side effects. That's one of their main issues with going on PrEP. And if I can have an honest conversation with them about, here's TDF-FTC, here's TAF-FTC, here's cabotegravir. These are the things that we've seen in each of the studies about each of the drugs. I found that makes them very comfortable. So I do talk about the kidney dysfunction and the slight decline in bone mineral density that's reversible with TDF-FTC. I do talk about maybe concerns of a little weight gain or the lipids going up with TAF. FTC and injection site reactions and weight gain with cabotegravir. But I lay it all out there, and I try to be as frank and honest as possible, and I found that patients really appreciate that, because then they feel like, and I use numbers and facts, and so I think that they kind of think, okay, well, now I have a good concept of what's going on, and this provider who seems to have some knowledge about this has given me a way to make an informative choice today.
And I think that we do that all the time with other medications, right? I was thinking about the person who I started on some antihypertensive medications, right? Like that you have options and you have potential side effects that might come along with those options, and then giving that information to our patients so that they can make a decision. And I think we do have this balance, right, of going against ads or even communication or conversations that our patients are having with their friends around what PrEP options they're on. and why they would want to be on one or on another. And I do, I did talk about, what the difference in renal dysfunction is between FTDF and FTAF, and like that it really isn't, in the studies at a level that, makes any difference clinically, like that I wouldn't make a different decision for your health based on that difference, and that we didn't see fractures, even though we saw these declines in bone mineral density, which was not ever how that test was developed to evaluate. And so I do give that context to people so that they understand that, the best choice is the one that you want and you will take, and then move forward from there. And I think that the weight gain is something that I do mention, and honestly, that is oftentimes the reason somebody will make a decision, not to do FTAF, to be frank. And so just giving people information so that they can make their decisions.
Yeah, but that's such an important point about what's clinically meaningful and what's, a biomarker difference.
Yeah, I really like the way you're both sort of thinking about this. I think it's very similar to how I conceptualize it, really trying to keep the overarching concept being the best prep strategy is the one that a given patient sitting in front of you is going to be able to adhere to, right, and stick with, right, right, and this person, that we're talking about, Skylar, he did not want to go on an injectable medication, which is fascinating to me. I think there's a lot of community-based pressure to or not to seek injections in different contexts all over the world. Sometimes people think that an injectable medicine is the best medication, and they're actually not happy until they get an injection of something before they leave a provider's office. And sometimes it affords discretion, right? Because I don't, have you guys had this situation where people don't want to be seen carrying around a pill bottle or being found with pills that could be confused by somebody who doesn't understand with medicines that treat someone who is living with HIV and therefore think that they are a person with HIV already? Have you come across that?
Absolutely. There's definitely stigma around HIV prevention and care and infections in the U.S. And then we have, for many of our patients for whom there's housing instability, so don't necessarily have a usual place to sleep, having and keeping tabs on a bottle of pills is another challenge. So there's a variety of like social determinants that might impact somebody's ability to adhere to an oral daily regimen that the injectables would alleviate.
Yeah, sometimes they don't want their partner to see it, so it's many different reasons.
Let's talk a little bit about what happened with Skylar. So we had a big conversation about long-term FTDF use and renal function, talking about these data that we've already talked about, that starting from a low baseline probably put him in a place where he was more likely to have this outcome. But I've always found it reassuring that as long as we have it in our minds that this group of individuals over age 50 and starting with a creatinine clearance under 90, that if we need to monitor them more frequently, it's most often reversible, and that they're not going to end up on hemodialysis or with a very severe manifestation, and that there is time to pivot if we believe indeed that this is the optimal strategy for them with pre-exposure prophylaxis. We talked a lot about the Discover study, which was this comparison of FTAF and FTDF for cisgender men and transgender women, and that there was a non-inferiority finding, and it was on that basis that it got regulatory approvals. And I think we're all aware of these Discover data that for non-vaginal sexual transmission, we do have this non-inferiority result that's that it's extremely reassuring again to see the absolute numbers of HIV incidence in both arms being so low. And to me, that's really the take-home message from this study, is both agents are highly effective. How do you guys approach this situation? We talked a little bit about this in one of the other cases. If someone has an injection drug use risk factor, but they're also having intercourse, right? It's pretty infrequent that somebody's only risk factor is injection drug use, and yet we always make this caveat when we talk about the different strategies of saying, well, we don't know if it protects against injection drug use. But that's not all. That's not people's only risk, is it?
Right, they're not siloed.
Yeah, and So the way that I generally approach it is, we do have really good strategies to prevent, injection drug use associated transmissions of HIV through syringe services, through support with Clean Works, those kinds of things. So I really try to have a conversation about like what are the strategies that somebody is using, and use that to inform. Because if somebody is using injection drugs, particularly in the setting of stimulants, and then they have actually higher sexual risk in those settings, but they actually don't have a lot of IDU risk because they have access to all the clean needles and testing for fentanyl, which I think is something that we are integrating into our harm reduction strategies as well. Then it really becomes about the sexual risk, and that really is, even though they do have both activities, their HIV risk is actually from their sexual exposures.
Yeah, and so I'll fill you in on what happened with this particular patient, in that we sort of considered all of these different options. He absolutely did not want to hear about an injectable. He's completely needle phobic, and there was no way I was going to convince him otherwise, and that's fine. And so we actually did daily oral FTAF, and he's doing great on it. And so I think as we've been discussing, for me the take-home message is, we're lucky enough to have a menu, and the best option is going to be the one that someone is able to tolerate safely for the long term. Because as you said, Dr. Scott, if they end up discontinuing and not telling us, the next thing that's going to happen is they're going to unfortunately be returning to our care as someone with HIV, and we want to avoid that if we can.
Right.
Yeah.
Right.
Thank you both for a really great and vibrant discussion, and thank you at home for joining us.